So does anybody know what the Medicaid buy-in program for the workers with disabilities are? I'm not asking you, Doug.
Okay.
No, you do. No, you don't. Okay. Well, back in the 90s, when the Congress could actually pass a budget, there was the Balanced Budget Act of 1997. And it authorized the Ticket to Work and Work Incentive Improvement Act. And as part of Ticket to Work, there was a part of it which allowed state Medicaid programs to expand eligibility for the Medicaid program to, I'm going to just turn this off if I can. Can you edit this out? Disabled workers above the income standards and resource standards of the Medicaid program. And so states were allowed to, through a state plan amendment, to change their Medicaid program to allow disabled workers with higher incomes to have Medicaid eligibility. Now, why is that important? You guys have some idea why that would be important?
Insurance.
Pardon me?
Insurance?
That's right. So that disabled workers could get insurance. What was happening was disabled people, in order to get their health insurance through Medicaid, lowered their incomes, either by not working or working part-time or working at a lower paying job in order to get their health care benefits, which they needed quite a bit. And so what this did was it allowed disabled workers to continue working and to maximize their income potential within reason, although the eligibility standard for Ohio's Medicaid buy-in program is 250% of the poverty level, but there's lots of income disregard, so the effective impact is over 400% of the poverty level. And you'll see some numbers later on, which shows you what that means for an individual with an income of, 400% of the poverty level. You'll see what those income levels are. Before we get started, we say that this presentation is on our website. It's at grc.osu.edu. If you have an iPad in front of you, you could link to that and you could look at it on your iPad. Also on our website is this report, which was put together for the Ohio Developmental Disabilities Council last year, and that's the full text of the discussion we're going to have today. So if you have a report to write for class, you probably could fall asleep right now and read it later. So first I want to tell you a little bit about the Colleges of Medicine Government Resource Center. This is an organization which is in the Office of Health Sciences at Ohio State University. Our vision is to become Ohio's academic resource for health systems change. And we have over 170 faculty members at all of Ohio's public and universities and Case Western Reserve University, who are either in colleges of medicine or affiliated health sciences colleges that are interested in providing services to state and local governments. And so what we do is we connect that resource, that expertise, between the colleges and state and local government agencies, so that if a state agency needs expertise in autism, or if they need expertise in healthcare quality improvement, or if they need expertise in health economics, they can come to us and we'll find the faculty member who can provide services to them on a consulting basis. Our areas of expertise are medical clinical, healthcare quality improvement science, health services research, workforce development, and we administer some cost containment programs for the Medicaid program. Our key client is the Ohio Department of Medicaid, although we have an agreement which serves 5 state agencies and is funded by federal and state funds. This particular study, which is an evaluation of the Medicaid buy-in program, was a grant from the Ohio Developmental Disabilities Council. It was facilitated through Medicaid Technical Assistance and Policy Program, and that's our contract with all the state agencies. Contract with the Ohio Department of Medicaid and the Ohio Department of Developmental Disabilities. What they did was they allowed us to use Medicaid data to do this analysis. We hold over 13 years of Medicaid eligibility, claims, and encounter data for the Medicaid population in the state, and that allows us to drill down into Ohio's Medicaid program and figure out what's happening and what issues might be occurring. Authors are all folks from the Government Resource Center and Bill Hayes. I'm going to do an introduction and overview, and then Bill is going to talk a little bit about the potential impact of the Affordable Care Act on the Medicaid buy-in program. One would assume that's already having an impact now that people can sign up for January. Talk a little bit about methodology and our research aims. So first, let me talk a little bit about the MDI program. Back in 2006 and 2007, when we were putting this project together, we did a budget and we did a fiscal analysis of what we thought would happen. And the program actually came up in April of 2008, and we had predicted that there would be 7,000 people enrolled in the first 36 months of the program. That we figured that 25% of the people enrolled would not be previously enrolled in Medicaid prior to becoming buy-in. That basically would be new eligible populations that weren't already eligible for Medicaid. They were basically attracted by the value of the buy-in program to their work history. We estimated the cost for newly enrolled at full implementation to be $14 million. Not very much when you think about that for new enrollees. And we estimated that 54% of the enrollees would be paying a premium, and that per member per month cost would be $835 a month in, say, fiscal year 2009. What's interesting is, throughout this you'll see some of the results of what actually happened. And while the Medicaid buy-in program has been very successful, at least in the first 36 months of the program, there was some variation from these estimates. We did not enroll as many people as we thought were going to enroll, and less of them were new enrollees. There were some surprises. Most of the population were developmentally disabled as opposed to physically disabled, and then fewer of them actually paid a premium. So we'll see what the story is with that. What we did in the study is evaluate the main purpose of the Medicaid buy-in program, and that is to make health insurance more accessible and affordable to workers with disabilities, so they can work and make a living at a decent wage. As I said before, many of the disabled were lowering their income in order to be eligible for Medicaid. This allowed them to still be eligible for Medicaid and earn a decent wage. So the main question for us was, does Medicaid enrollment increase the likelihood that a person with disabilities will be working? And we actually found that to be true. Some background information. These are the employment rates of the disabled and non-disabled population in Ohio. This information goes from 2008 through 2011. This is from the there's a federal census program which collects unemployment information, and for a while there they were tracking the unemployment of the disabled population. They actually shut down this program, so we can't get that information anymore since after 2011. I guess maybe the government just didn't want to know. Little editorial comment there. But the unemployment rate of the disabled population is almost twice as high as it is of the regular population. And as the unemployments of the non-disabled population have fluctuated, so haven't those of the disabled population. This is the budgeted versus actual enrollment in the Medicaid buy-in program. That's what we budgeted, that nice curve, and what actually happened was somewhat less. And by June of 2011, we still hadn't, we had finally reached the estimate that the budget had put together. So that's a little background on the Medicaid buy-in program. Bill's going to interject some interesting information about the Affordable Care Act.
A small little bill that seems to be causing a ripple effect in Washington as we speak. So, back in 2010, we passed the Affordable Care Act in response to rising uninsured, fewer people getting employer-based coverage, problems in insurance markets with pre-existing conditions, and other things led to President Obama and the Democrats in Congress passing the Affordable Care Act. And so there are several provisions in this act that have potential to impact the Medicaid buy-in program. And I'm going to go through each of these individually in a moment, but those include the individual mandate, the health insurance changes in terms of pre-existing conditions and such, having these health insurance exchanges such that people may be able to buy care in a different way, premium cost-sharing subsidies that's tied to if you get coverage through the exchange, the creation of what are called essential health benefits that health plans are supposed to offer, Medicaid expansion, and something that's called the health home provision. So I'll go through quickly each of those. So the individual mandate. Under the Affordable Care Act, everybody is supposed to have now health care coverage effective January 1st, 2014, or pay a penalty. The logic for this was that if you're going to do some other provisions I'm going to talk about in a moment, such as get rid of pre-existing conditions, get rid of annual lifetime limits and such, the insurance company said, then you must have everyone have to have coverage, or they'll just wait till they're sick and I have to take them, come what may, and that will blow up the insurance industry. So we put a mandate on. But there were a couple of exceptions, and one exception is if the cost of health care coverage exceeds 8% of your income, then you could say it's hardship. I can't afford it. There's also some religious exemptions and some other pieces in there. So for uninsured persons with disabilities, the Medicaid buy-in program now may become an option. I hadn't taken it up. I have this mandate. This may become one choice of how I get coverage, assuming Ohio maintains the Medicaid buy-in program. Because I will say that there is one piece of legislation in Ohio that has proposed taking it down as one of the Medicaid reform proposals in Ohio, because if that legislation wants to take Medicaid back to the bare minimums for all coverage. I doubt that will move, but it's out there. So, trying to figure out how the mandate will play will be an interesting question over time in terms of what choices may people decide. Second, there are these uninsured insurance underwriting changes. So obviously, people with disabilities, I experienced this when I started working at the Bureau for Children with Medical Handicaps. One of the first things I ended up doing there was writing a manual for how to fight insurance companies. And the denials that they were giving you for covering certain things, people being rejected from being covered and whatnot. I also helped them fight Medicaid denials, I will say as well, that they were having at the same time potentially. The ACA prohibits or significantly reduces a lot of these insurance practices. No longer are you to have a pre-existing condition clause that would prevent you from covering someone. You're supposed to be covered from day one, whatever you have. I have my son-in-law's nephew was born deaf, and the insurance company said it was a pre-existing condition, and therefore would not cover the hearing aids and other things that the child had. That would no longer happen. There are also, these things could price you out of the market as well, because what they might do is to simply say, I'll cover you, but I'm going to charge you a premium that's multiple times higher than what others might get, based on the logic that you're going to be using more services, or you might be using more services. So they're doing things to lower that. Now there's only a 3-to-1 difference allowed in premiums, which means the healthy people may pay a slightly higher premium, but the older and people with a chronic condition would pay a lower premium than otherwise would have been the case in Ohio. The goal is that may make things more affordable. They're also getting rid of annual limits and lifetime limits on coverage, because one of the issues you might have if you had a lot of use was you had coverage up to $50,000 for the year or $100,000 for the year, and then basically you had no coverage. So those things are going to change, which may make private coverage more attractive, more available. So the question is, from a person, will more people therefore who might be on the buy-in choose the private coverage option, because before they were kept out of it? The third possibility is what's called the health insurance exchange. In every state, there's to be, and they started on October 1st, and a health insurance exchange either run by the state or federally facilitated. In Ohio, it's federally facilitated. We're not running our own exchange, where people can come, and there's a series of plans that vary by state that said, I want to provide health care coverage, and at 4 levels, bronze, silver, gold, and platinum. And the standard policy is considered like the silver plan. And those plans have different levels of co-pays and deductibles, which basically affects which level you're at. The higher you go up, the less out-of-pocket costs that you have, maybe a few more benefits. Bronze is the base, the lowest plan, all the lowest premiums, and it'll have the most out-of-pocket costs. It'll have the most limits on policies potentially that could be there. And you're to come to this exchange and have a seamless opportunity, ideally, to choose among the plans, as well as to be considered for Medicaid eligibility. So if it runs properly, it should also be assessing whether or not you, as a person with disability, might be eligible for Medicaid buy-in or regular Medicaid, and give you your choices. And there are to be people who are navigators, who are to kind of help you sort through those, because not every person is going to be able to go on their own and go, got this figured out. And there are issues as a person with disabilities that you should be thinking about in buying coverage that someone else might not be thinking about. If it's the first time you've gone to buy coverage, maybe you need help thinking about, go back to the back and look about what their medical equipment policy is or whatnot. So there are to be these navigators. And in fact, in Ohio, I came to learn just in the last few days, that Ohio got a grant for navigators through the Second Harvest Food Banks, and Disability Rights Ohio got part of that grant for the purpose of creating information for navigators about how to help people with disabilities when they come to you think about their options. So that's good to know that there'll be some information out there. So ideally, this is going to create a more affordable marketplace. The premiums are to be lower than they might otherwise be, because you're buying for this larger mass of people rather than a group of 3 or 4 or 5 or 1. So the question is going to be, will buy-in eligibles now go there and be told they can be on buy-in and take buy-in coverage? So we might see an increase in buy-in. Or will some people go there and say, oh, I can have private coverage, and choose to have private coverage? Now, one of the things on the health insurance exchange that's going to happen is if you go to the health insurance exchange, you may be eligible for premium and cost-sharing subsidies. When you think about our current world, who's got insurance through their employer right now in this room? Most of them. All of us get that with tax breaks. The single largest tax deduction in the United States is for health insurance. And it comes to your employer. They get a write-off, basically anything they pay before they take their tax. And it comes to you because any premium you pay is in pre-tax dollars. So it's taken off, so that doesn't count as income. And your income is lower. Well, anyone who's uninsured, or anyone who buys on the individual market, they don't get that benefit. They're paying taxes to support our benefit. So what the Affordable Care Act said is, that doesn't seem right. We should provide subsidies to these other people as well. And so what they've set up is anyone with an income between 100 and 400% of poverty who comes onto the exchange would be eligible for a premium that will have a sliding. It'll be more at 100 and less at 400% of poverty. And so a premium that might be $600 a month after the subsidies might only be $200 a month. So when someone looks at the exchange, they shouldn't just look at the first ticket price. They need to put in, am I eligible for these premium subsidies or not, and what does that mean? It also includes cost-sharing subsidies, because these plans have varying levels of deductibles and copays. And between people with incomes between 100 and 250% of poverty will be eligible for cost-sharing subsidies. It could mean that a $1,500 deductible might be $200. So again, before someone makes a choice, they need to understand what these subsidies might mean, which is why you need a navigator, and some other people, and some good information to help you sort through those, especially if you're a person who has an intellectual disability or some other dementia or some other issues going on. You better have someone there helping you sort through your choices. So these subsidies are going to make the health plans sold on the exchange more affordable and more attractive. So now with these subsidies, someone who's in buy-in might say, I'd rather take the private coverage than Medicaid. And they might like that because it's possible that on the private coverage, they think a provider might be more willing to see them than see them with a Medicaid card. That may be one reason you decide you want to have private coverage. So we're trying to understand how, but this could be one of those dynamics that will come up. Essential health benefits. There are 10 areas of essential health benefits. And for the first time, habilitation is one of the things mentioned as an essential health benefit. Now it's left up to the plans to some degree how they define what is habilitation and what is rehabilitation. But private plans may now cover some habilitation services. And in Ohio, we got explicit around autism and said certain things that had to be covered under autism under this. But we're less explicit under some of the other policies. So someone needs to actually read the benefits and say, what do you mean by habilitation under policy A, B, C, or D? Again, this is where a typical broker or insurance agent who might be helping may have no clue on this stuff because they never really had to deal with that. And the information for Disability Rights Ohio and such could be very helpful for you thinking through what you want. These benefits, however, are less robust than the Medicaid benefit, because Medicaid covers a lot more services and without cost-sharing obligations and such. So the Medicaid package is still going to look better. The Medicaid buy-in package is going to still look better. Though remember, some people on Medicaid buy-in above 150% of poverty have to pay a premium. So they may judge what's my premium on that versus my premium on the exchange. So we got an issue. How are we going to help people on the buy-in be able to compare their choices? And will the benefits covered by the exchange make the buy-in still a preferred option? Where do you want to go on it? Again, as I said, the other trade-off is the provider network going to be more accessible from a private package than potentially from having Medicaid, because the Medicaid rates may be lower than the rates that you pay in the private plan. Medicaid expansion. So one of the things, so I told you, you have these exchanges and they give you premium subsidies from 100% of poverty to 400%. They don't give you subsidies for anyone below 100% of poverty, because we assume that everyone below 100% of poverty would be now eligible for Medicaid, because there's this thing called Medicaid expansion. Right now, not everyone who's poor is eligible for Medicaid. You got to have a parent. You got to be a parent with a child that's and you're the custodial parent, and you have to have an income. In Ohio, that income is 90% of poverty. In some states, it's higher. In some states, it's 20% of poverty, 20, 30% of poverty. If you're a person with a disability, you're eligible for Medicaid, but only if that disability is significant enough to qualify for Social Security disability determination, which basically means you can't work. So you could have cancer stage 2 and not be eligible until you're cancer stage 4. We used to have a problem, which is why the buy-in program came, that you could have schizophrenia, be unable to work, get on your medications, become stable, can work. Now you can make money, you lose your ability to have Medicaid, you lose your medications, you become unstable, and this yin-yang was really foolish. And so the buy-in program was kind of coming in to help that. Well, now what Medicaid expansion was saying is any adult 19 to 64 is eligible for Medicaid with an income up to 133% of poverty. But they gave a 5% income disregard, so it actually means 138% of poverty, which is why you see 138% of poverty here. So every adult in Ohio, regardless, no asset tests, no other obligations, is eligible for Medicaid up to 138% of poverty. The Supreme Court complicated this because they said this is now, you can't force this on the states. This has to be an option, so each state must elect to expand Medicaid. Governor Kasich proposed that in his budget. The House and both Republicans, the House Republicans and the Senate Republicans refused to support that. So at the moment, Ohio's not doing Medicaid expansion. There is now an effort to go for a constitutional amendment, and petitions you may see people trying to get to sign, so that a year from this November, if the state legislators don't move on this, we could try to have a Medicaid expansion. In the case of the administration is still working on this. So if Ohio elects, then everyone in the buy-in program currently with incomes below 138% of poverty might say, I'd rather not be in buy-in because I don't have any cost sharing or premium, or if there are certain obligations that comes on it.
And you might not also have to work.
You don't have to
Or
work.
not show that you're working.
You know, and you don't have that work obligation. So if you were finding that tough to do, Ohio would have an interest in you actually moving you off the buy-in program, because if we could count you as newly eligible, the feds would pay 100% of the premium of the cost on buy and that population, versus right now they would only pay 63 cents on the dollar, and we would pay 37 cents. So there's financially for the state, we would like to move anyone we could into this newly eligible and get the feds to pay more of their dollars. So states, however, can also decide with expansion, they could create a benefit package that's skinnier in Medicaid expansion if they elected to, more like the essential benefit package. So in that case, if that happened, then if you're in the Medicaid buy-in, you might say, I'd rather stay with the regular Medicaid buy-in program because its benefit package is better than what expansion will be. So lots of moving parts to understand how this might play.
One of the things that's different about the essential benefit package that for Medicaid is it does not cover long-term care services, no long-term services and support. So anybody who has a long-term care need would be better off staying on Medicaid than going into
the
health
other thing,
insurance exchange.
And the other thing is, you know, for the expansion, they don't cover long-term care. So if you want long-term care, you're going to need to come through the regular Medicaid window.
Got a question?
Yes.
Bill, you said with Medicaid expansion, the criteria changed, not just with the poverty level, but that all people that fall in that age can be eligible.
Yeah, so they're not going to do a disability examination for you. Your health status isn't an issue. It's purely your income and your age.
No kids.
Don't have to worry about it, whether you have a child or not.
Okay.
At one point, I jokingly said we could solve two public policy programs given how Medicaid runs. One, if everybody in Ohio adopted someone off of child welfare roll, they could then be eligible for Medicaid if their incomes were 90% or below. But they may not be the ideal parents. I mean, but the way your system was set up, that became kind of the weird criteria. Have a child, get Medicaid. Now you wouldn't have to worry about that. You would have Medicaid regardless of that. The final provision is inside the law. It also creates this opportunity for states under Medicaid called Health Home. The goal here was to promote chronic care management. And this is a program where you have to have 2 or more chronic conditions. And they were going to give the states enhanced match at 90% federal, 10% state for 2 years if you tried to do a health home effort. The reason for this is the logic is you spend more money most on the chronically ill than you do for anybody else in the population. If we could bring in better chronic care management, we might be able to bend the curve of spending for Medicaid or other programs. So Ohio is looking at doing a health home, and their first effort had been to integrate physical and mental health services. So one chronic condition had to be that you had severe persistent mental health illness, and then you also have to have some second condition. And they're doing this through community mental health centers, not through other providers. So here you have an interesting question, because you might get better chronic care management, you know, if you were in a health home program and a working person with disability who might have severe persistent mental health and another condition, and that might cause you to want to stay on Medicaid than go to a private plan. In Ohio, we've been staggering about implementing this. It's gone back to be revised, so it's not really, there's 5 counties where it's happening right now. So those are some of the provisions in the Affordable Care Act. Much of this starts January 1st. Right now, people are enrolling on the exchanges. Those pre-existing condition clause changes will all take effect January 1st of 2014, unless something comes out of this that says it's delayed or other things that might happen that Congress is in trying to push the president to do. Any other questions on the Affordable Care Act and the buy-in program before I hand it back over to Lauren?
Well, there are a couple things you said that I didn't fully understand. You said that an exclusion from the individual mandate was if the cost of the health insurance premium was 8% of your income.
Right.
Wouldn't the subsidies kick in at that point?
So generally, the subsidies should take care of the people above 100% of poverty, but since there's no subsidies, it means that anyone who, if we don't do Medicaid expansion, all the poor people will be able, below that will probably be able to argue, I don't have to have coverage because of this hardship, financial
So
hardship.
if they're between the
Both-
Medicaid rate and.
Right. You know, but the subsidy should help get rid of that as being a reason that you can't get coverage. But some people still might have a situation where they might make an argument that, you know, I can't afford my employer's coverage, but if my employer offers me coverage, I'm not eligible for the subsidies either. So if your employer offers you coverage right now, that's considered affordable, and that means, and there the test is 9.5% of your income. So if the premium costs you more than 9.5% of your income, then you could go onto the exchange. But otherwise, if you're a worker and you went to the exchange and they said, does your employer offer coverage? Yes. What's the premium cost for your employer coverage for an individual policy? Well, you're not eligible for the subsidies because you should be buying it. You know, so you could have someone who might be in that 8 to 9.5% range.
Okay.
Any other?
Another question, sorry.
Yeah.
I thought Medicaid buy-in meant that you had to pay a premium. You buy into the access to Medicaid.
Yeah,
coverage.
that's over 150% of the poverty level is
Okay.
when the premium.
So the low,
payment
So between
starts.
90 and 150.
or between 0 and 150% of poverty, someone there doesn't have to pay. You know, if someone has minimal income, you know, that they wouldn't have to pay a premium.
And they just elect to be in the buy-in program and be able to vote?
Yes, they would elect to do that. And it might be a case where, again, you know, it may be that their income is balanced. You know, they went into buy-in, but they stayed in buy-in, but they're working part-time, and so they're uncertain whether they'll be above the 64% of poverty. Because remember, for the age-blind disabled, the income is 64% of poverty,
Okay.
you know,
Okay.
for that group. So generally, 64 to 138% of poverty group could be in the buy-in program, or 150% could be in buy-in program and not paying premium. And then the people above 150 pay premium.
So this table shows you what the premium payment is at different percentages of the poverty level, comparing the Affordable Care Act with the Medicaid buy-in program. So the ACA premium is calculated as a percentage of gross family income, ranging from 2% at 100% of the poverty level to 9.5% of the poverty level at 400% of the poverty level. Where the Medicaid buy-in premium is calculated as 10% of the family income above 150% of the poverty up to 250% of the poverty level. So if you calculate what those premiums are, at 200% of the poverty level, the premium for the Affordable Care Act is $88 for one person, and it's $47 under the Medicaid buy-in program. Now, if a navigator gave you those numbers, what are you going to choose? You're going to choose the buy-in program. Unless there's some other compelling reason why you feel like you want to pay twice as much. Just remember, at 200% of the poverty level, $50 is, you know, it's a lot of money.
What is the federal poverty level?
Column
100% of the poverty level is $931 a month for a family of one, $1,261 for a family of two.
And that's pre-tax. That's before taxes are taken out.
Mhm.
That's not your take-home pay.
Okay.
Those premium estimates include the subsidy, right? But you get reimbursed later, so it's actually a lot higher at first, right?
No, subsidy's taken out right away.
Okay.
Yeah, so this
Subsidy-
is the value of the subsidy.
Subsidy is basically assumed and then paid directly over the insurance plan by the government.
Okay.
So you don't pay and then have to get that money back because of that issue.
So after the ACA implementation, we estimated that the most favorable coverage for workers with disabilities, and this includes only those that don't need long-term care services and supports, they're going to stay on Medicaid because they can't get it anywhere else, is if you're less than 138% of the poverty level, your best coverage category for a disabled adult that doesn't otherwise isn't otherwise eligible for Medicaid would be the Medicaid expansion. That's what Medicaid Community Development means, the Medicaid expansion program. And the reason is because there's no work requirement and there's also no premium requirement. If you're 139 to 150% of the poverty level, you're better off in the Medicaid buy-in program because there's no premium and no copay. And then above that, you're better off in the Medicaid buy-in program because there's a lower premium and no copay. So we also estimated coverage shifts for the disabled population, disabled workers, using information from Medicaid eligibility and claims data and information from the American Community Survey. We estimated that 2,300 people would move from the MBI program to the Medicaid expansion because their income was between the current eligibility standard and 138% of the poverty level, and they could do so without having to document that they were working. There are uninsured workers with disabilities below 138% of the poverty level that are not on Medicaid. Of course, they're going to be required to have some coverage, and they are probably going to choose the Medicaid expansion program, and there are around 20,000 of those people. And then finally, there are uninsured workers with disabilities between 138 and 400% of the poverty level. And they're going to more, there's 20,000 of them, 21,000 of them, and they're more likely to take the MBI program because the subsidies, because the premiums are less. Now, these are just estimates from the American Community Survey. The estimates don't include assumptions about take-up rates. There are some people who won't choose anything and they'll be in violation of the law and then they'll end up paying a tax as a result of it. But the potential is up to 21,000 additional people in the Medicaid buy-in program as a result of this.
That's Lauren.
Yeah.
So if we don't have Medicaid buy-in in Ohio, what do they do?
They would be.
I mean, if we don't have Medicaid expansion.
If they don't have Medicaid expansion,
If we don't have Medicaid expansion in Ohio.
well, I think
what do they
just
do?
like every, they would go into buy-in. Yeah.
So Medicaid expansion, if I heard correctly, the federal government would pick up 100%, but if they end up, those 21,000 end up going into buy-in, the state pays 37 cents on the dollar.
Right.
So why would the state not do expansion? It sounds like it saves money.
Well, this is a very small population compared to the entire Medicaid expansion population. So we're talking about 275,000 people versus 21,000.
But I think so the question on Medicaid expansion is that you have it's a fairly ideological debate going on right now as to one, that's more money the Fed's spending, and should we increase the federal deficit? Two, can you trust the Feds to keep the deal at the 90%, rate, or might they change it? And just three, they just don't like the Affordable Care Act, and therefore they're opposed to it. And even if doing Medicaid expansion would seem like it's accepting a part of the Affordable Care Act, therefore, they're unable to decouple the two. Even though we've had prior Medicaid expansions in the past, Lucas are not part of the Affordable Care Act. And though there is data to suggest that, in fact, the state can manage, has enough savings to make it worthwhile and affordable to do, even when the match goes to 90-10, that hasn't been enough to sway the legislators at this time in the politics. So there's a lot of that push. There's also an argument out there that it's better to be uninsured than to be on Medicaid. And looking at certain studies and making an argument that Medicaid's a broken system. I've got a report out that you can Google that's tried to look at those studies and say, not quite true. But there's some of that going on. But there's just a lot of, we don't like this because it's been proposed by Democrats, and we don't support it.
Just out of curiosity, so obviously there's going to be some sort of tax repercussion if you choose not to have insurance. Is that gonna also be on a sliding scale, or is that
So
gonna
the
be
so
just
the
X?
tax the tax implication is not on a sliding scale, but it's also incredibly but it is modest at the moment. So for the first year, it's $92.
And they're not gonna come out and arrest you if you
You know, it's
Right, so really to me, there's no reason for people to get insurance if they're gonna get, if
Well-
they don't wanna pay for insurance, that $92, that's
Yeah.
not anything.
So the
compared
argument
to
is, there is a
insurance.
question about whether that's enough. Now, the other thing, though, is that there's an open enrollment period, like, when you go to work, you can enroll once a year.
Right,
Okay, so right now you can enroll from now till March to get coverage. And if you don't enroll in March, then you have to wait till the next open enrollment period. So you run the risk that if you then got sick and had something, you can't immediately walk in and get coverage because you might not be in an open enrollment window. You know, so you have to make you're making your bets.
yeah, I guess I'm just curious, and this isn't something that I know.
And then
a
also
lot
the
about.
the health safety net is gonna start to close. So that there's money out there that the states use to pay for uncompensated care.
Right.
And that is going to evaporate at some point.
But
So you're gonna be on your own.
you were gonna, yeah,
I guess because to me, I see that people who are young and see themselves as healthy, and obviously we all know you can go from healthy to unhealthy at any point in time, but people who are young and see themselves as healthy, people who don't use the system very much are who make the system solvent. And to me, it seems like if $92 is your only, punishment, why, if you're young and healthy, do you not join the system? And then if that's the group of people not joining the system, how is it ever gonna be solvent?
right. So you got two things. One, the penalty will increase over the first couple of years, so it'll become a little more significant. But that's a very big worry people have. In Massachusetts, they got a lot of people came onto coverage and their uninsured rate dropped significantly, and they had a small penalty. So the Massachusetts experiment suggests that when offered, people still felt risk averse enough that they went out and did that. But that is a concern, that people will opt out, and then there is actually a campaign going on now by people opposed to the Affordable Care Act to encourage young people to opt out and telling them how low the penalties are and such. So it will be interesting to see what effect that happens. But that's a risk, and then you might get an amendment to say, okay, we have to increase the penalty if people wanted to. We'll see.
Yeah.
Do you have, or have you thought about the implications on unemployment? Or as more people join or would participate in Medicaid buy-in, would the unemployment rate drop? Or are we just talking about the same, a group that's employed but better employed so that it doesn't affect the unemployment figures? As more people would join into buy-in?
We did not estimate that. We did not consider in those numbers the 20,800. We did not consider the changes in the unemployment rate. We just assumed that the unemployment rate differences would continue the way they were.
Does the modified adjusted gross income standard that they started on the first change those numbers significantly? I don't know how much it changed the Medicaid eligibility.
We were using MAGI when we calculated. We were using that when we calculated
Yeah.
those numbers.
And you talked about how the new integrated eligibility system can talk to the exchange. Is it specific enough to say you're eligible for the Medicaid buy-in program?
I don't
Does it
think we
do
know
like
the
a
answer to that
comparison?
question.
I haven't seen it, so I don't.
Nor have we.
No
To
one
see,
has.
to see what.
Right.
So nor have we. Ideally, one would think it would work you through some of your choices in the programs, but I haven't walked through to see if it was successful.
Other questions? Yeah.
I saw at Cleveland.com, I think that navigators in Ohio are not allowed to compare and contrast plans for people. Is that accurate?
So we have a state law that was passed that put some restrictions on what navigators can and can't do, because there was a concern that they weren't insurance agents and they might, be skewing what was being talked about. Which is interesting because the insurance agents are typically getting paid by some plans and not other plans, so I was curious why they didn't apply to all. So there were some restrictions that got put out there. I think that Children's Hospital in Cincinnati pulled out of being a navigator, but I was talking to some people going, what they said didn't make sense to me, and others said no, it didn't either. They just used it as it was more convenience to get out of something they realized they weren't wanting to do in the end. But so I think they can do more than, but there are some limits, and so there are certain groups that can't be navigators. So anyone who got federal money to be navigators has some more freedom than people who didn't get federal money. But Disability Rights Council was telling me they also were thinking about potentially suing the state on grounds that you're trying to have state law supersede federal, and is that going to be possible or not? And they said if we had our druthers, we would just, because that's what we do, we're lawyers, we would sue. And in Tennessee, there's a lawsuit that has been filed by some people against a similar restrictive thing, saying that you're overturning federal law, and that's what we should be able to do. So there's an interesting tension there. So we'll see how it plays out. But that's why some people backed away from wanting to be navigators, because they were concerned about the penalties that were being put into the system.
All right, we're going to continue and talk about the rest of our evaluation of the Medicaid buy-in program, talk a little bit about the methodology. We used Medicaid data that included Medicaid eligibility claims and managed care encounters for Medicaid buy-in enrollees for state fiscal year 2009 and 10. And what we did was we compared the Medicaid buy-in population with the Medicaid disabled population for that time period. We took a random sample of 12,000 disabled Medicaid adults that weren't on buy-in and compared them to the population that was on buy-in. And we identified the differences between those two populations based upon their chronic physical health, mental health, and developmentally disabled diagnoses. We identified the levels and use of primary and preventive care, inpatient hospitalization, and emergency department utilization. And then we created a predictive model of the likelihood of having an inpatient hospitalization in the 2-year period. The reason we did all this was because it would have been a lot easier if we could have just figured out what the cost per member per month of a Medicaid buy-in person was versus the cost per member per month of the other disabled populations. That would have been easier, except the Ohio Medicaid program doesn't allow us to have access to information about how much Medicaid managed care plans pay their providers. That's considered a trade secret. They don't allow us to have that information. So we had to look at the utilization data to figure out if there were different patterns of utilization and whether the population on the Medicaid buy-in program was different than the disabled population by looking at the utilization pattern. And what we did find out was that on everything other than their demographic characteristics, there's a big difference between the buy-in population and other Medicaid. We also used the American Community Survey. We looked at the socioeconomic and health insurance status of the adult population. This is data from 2008 through 2010. We described the differences in unemployment of the adult population with disabilities, the adult Medicaid population with disabilities, and we compared Ohio with all the other Great Lakes states and Pennsylvania. And then we modeled the socioeconomic determinants of the differences. So we wanted to see what affected the employment rates of the disabled population. What were the key drivers of the differences? So with that, we calculated the odds that a person with disabilities is employed. What are the factors? To what extent does enrollment in Medicaid affect the odds of being employed? We did a logistic regression model for each state. So these are the questions from the American Community Survey. These are the questions which determine whether you're disabled in the American Community Survey. Had to do with you have either difficulty hearing or seeing, or even when you're wearing glasses. And if that was true, you were disabled. And if that wasn't true, they asked about a physical, mental health, or emotional condition, or they had difficulty walking or climbing, or does the person have difficulty dressing or bathing? And then because of those disabilities, do you have difficulty doing errands alone, such as visiting a doctor's office or shopping? So there's an algorithm which determines whether you're disabled based upon that. This is the state MBI programs in the Great Lakes region. All the other states in the region started their buy-in programs in the early 2000s, and in Ohio, we started in 2008. We looked at this because we thought that there may be a reason here for which there might be differences between Ohio's data and other states' data. It's really hard to differentiate the reasons why Minnesota has a higher employment rate for its disabled population than Ohio does, but at least here's some descriptive information about what each of the states' buy-in programs actually does. And note that the states have a lot of discretion as to how they set up their buy-in program, because CMS was not very prescriptive about what they could do.
Especially note the resource limit.
Yeah. Well, you guys know what an odds ratio is. You took statistics, so I won't go over that. Here's the demographic and eligibility summary of the buy-in population. More were male than female. There's a higher percentage of African Americans in the buy-in population than are in the Medicaid population as a whole. 21% black. I think it's 17% for the Medicaid population as a whole. Marital status, 74% of the buy-in population was single. 4% lived in a long-term care institution. 76% were eligible for both Medicare and Medicaid simultaneously. Those are known as dual eligibles. Interestingly, 27% of the population were on Medicaid waivers. They were either on the home and community-based care waiver, which is a waiver for patients with physical disabilities, or on the developmental disabilities waiver, which was obviously a waiver for patients on with developmental disabilities. 44% paid a premium. Remember, in the proposal or in the projection that we did in 2008, we projected that 54% would pay a premium, and in this case, only 44% were paying a premium in 2010. The average length of enrollment was 12 months. Medicaid has a problem about people having gaps in coverage because they're supposed to renew their eligibility every year, and if they don't, they lose their coverage until they fill out the paperwork in order to get covered again. And so there's a lot of churn of the population on Medicaid in and out of coverage. We found that with this population, the percent that had no gaps in coverage was pretty high compared to the covered families and children or other disabled. So they're much more likely to have coverage for 12 months than other Medicaid population. The average length of a gap for the 11% with a gap was only 1 month, a gap in coverage. The percent with no previous Medicaid eligibility was 20%. Remember, in the projection for the budget, we estimated there would be 25%. This is the monthly and cumulatively monthly enrollment in MBI. By April of 2011, there were 6,000 that were on MBI, and there was a cumulative unduplicated enrollment of approximately 12,000. You can see that the MBI program is growing and continues to grow because the number of new enrollments per month is is about twice as high, or a little bit more than twice as high, as the number of disenrollments per month. So if more people are coming on than are coming off, then the number of people on the program is going to continue to increase.
I have a question.
Yeah.
What happens back there between March and April?
I don't know. Don't know. It could be that there was a problem in March and the people who were supposed to come in March came on in April. Could have been a system problem. Don't know exactly. This is the member months and costs by care setting. Basically what it shows is that those, the community non-waiver population, 69% of the represents 69% of the member months, but only 19% of the total costs. Versus those that were on either in a long-term care facility or in a waiver, total of reciprocal 31%, 81% of the cost. Now, not surprising because the cost of long-term care dwarfs the cost of acute care. And also because so many of the population is dual eligible, Medicare and Medicaid. For those that have the acute care benefit that are dual eligible, Medicaid is only paying for the copay for the Medicare costs. Expenditures for the Medicaid buy-in program in 2010. Total expenditures were $103 million in 2010 and $13 million for new employees. And that is all funds, all agencies before pharmacy rebate. I don't even want to explain pharmacy rebate, but this ends up being less than that $14 million estimate for 2010 that was in the budget. But it's actually probably around $11 million. And one of the reasons is because of the issue around the percent that were newly eligible was lower, and also the percent that were dual eligible was so high. So here's the per member per month expenditures for the population. Those are previously eligible versus new enrollees. There's essentially no difference. Those are on long-term care. Almost 10 times the cost of those who are in community and non-waiver. Dual eligibles were less expensive than Medicaid only. And for those that were in long-term care that were dual eligible and paid a premium, the cost of their care was $6,300 versus those that didn't pay a premium was a little over $4,000. So this shows what the expenditures were for enrollees with long-term care services and supports, and sort of identifies what Medicaid was spending their dollars on for that population. So and this was for 2011. For that population, the Medicaid benefits, the basic benefit, the acute care was $48 million versus $183 million for the long-term care. And this is what the $183 million was spent on. A small amount was spent on nursing facilities. Intermediate cares for the intellectually disabled was $37 million. Ohio home care waiver, very small. Private duty nursing. Ohio Department of Aging waiver is very small. And the big enchilada was the MRDD waiver. For those who were enrolled in the Medicaid buy-in program, a huge amount of the expenditures were for the MRDD waiver. So that's basically telling you that most of the population in the Medicaid buy-in program were developmentally disabled. This compares the hospital utilization characteristics for the Medicaid buy-in program compared to disabled Medicaid adults. And you will note that the hospital utilization was much lower for the Medicaid buy-in program than it was for the other disabled population on Medicaid. This is hospital visits per 1,000 member years, 106 versus 299, 3 times higher for the Medicaid disabled population. 12 hospital visits for ambulatory care sensitive conditions, 57 versus 12. Emergency department visits, 2,300 versus 1,000. For those with ambulatory care sensitive conditions, 270 versus 93. So healthcare utilization by the Medicaid buy-in population is significantly lower than for the rest of the Medicaid disabled population. Is that because they're working, or are they working because they're less seriously ill than the population? A good question.
And perhaps younger.
No,
They weren't younger?
they're not younger. There are no significant differerences in the demographic or eligibility characteristics of this population. In fact, if you look in the back of our report, you'll see all the tables with the chi-squares and the significance levels of those differences. And there are literally no differences in that, in the demographic characteristics of the population. But there were significant differences in health conditions. In the MBI-WD group, they were 7.9 times more likely to have a developmental disability than the other Medicaid disabled population. They were 2 times more likely to have a cerebral palsy. They were 1.3 times more likely to have epilepsy. And interesting, there really weren't any differences in the likelihood of having a mental health condition, either bipolar neurosis, schizophrenia, or psychosis. They were more likely to have, less likely to have depression. 0.7 times less likely to have depression. And they were 2.2 times more likely to have no chronic physical health conditions. And I'll list off the chronic physical health conditions that we measure here, might be useful to you. Arthropathies or joint disorders, asthma, cerebral palsy, diabetes, epilepsy, head or spinal cord injuries, hypertension, nutritional disorders, osteoarthritis, renal failure, respiratory disorders, and spinal and back disorders. Those are the chronic health physical health conditions that we measured, and all they were significantly less likely to have those conditions. And then they were more likely to have had at least 1 primary care visit. They were more likely to have at least 1 dental visit during the year. So they were healthier, they used primary care more appropriately, they had lower hospital utilization. We calculated factors that influence the likelihood of having a hospital admission. And what increased the odds of having an inpatient hospital admission? 3 or more plus mental health conditions, renal failure, epilepsy, multiple physical health conditions. Decreased likelihood of having an inpatient hospitalization, spinal back disorders, developmental disability, and just being in the MDI-WD group, after controlling for all these other factors, they were 0.6 times less likely to have a hospitalization than the other population. So these are basically factors that we can't account for. It's just because they were in the MDI population. So there's some significant differences that we really can't account for. So the other part of the evaluation that we did was to compare the impact of Medicaid on the disabled adults that work, and we did this at a state level, comparing the states in the Great Lakes region, and we also did sub-state regional comparisons. So we looked at percentage of adults reporting a disability, percentage of disabled adults working, percent of disabled adults on Medicaid, and percentage of Medicaid disabled adults working. So here's our first comparison. We looked at the percentage of residents reporting a disability. Ohio, 11.7% of the 19 to 64-year-old population had a disability. Compares with Michigan and Indiana, somewhat with Pennsylvania. Illinois, Minnesota, Wisconsin, significantly less. So Ohio's in the upper tier of the states. We looked at it by what they call PUMA regions inside the state, and I'll flip backward and forward here. These are the PUMA regions in Ohio. Note that there are multiple regions within Cuyahoga County and the same within Franklin County. And then this is southeastern Ohio. So you can look and see that 39062 is Cleveland. And you look at 62 here, 18.7%, 18.8% of the adult population reported a disability in the city of Cleveland versus 8.8% in just in the suburbs of Cleveland. And I'll show you that. 61, that's the Medina area, just south of Cleveland. So we can do all this analysis at a sub-state level, which is very interesting. This shows the citizens reporting a disability by regions of the state. You can see the highest levels are in inner city Cleveland and in southeastern Ohio. The lowest levels are in suburban Franklin County, or I'm sorry, suburban Columbus, suburban Cincinnati, and northeast Ohio, other than in Cleveland. Percentage of disabled adults that are working. I think I mentioned this earlier. Minnesota, very high. 45% working. Illinois is also very high. Ohio, Michigan, Pennsylvania, Indiana are all in the bottom tier. Percentage of disabled residents that are Medicaid enrolled. Indiana, Ohio in the bottom tier. doesn't look like we're doing so well compared to the other states in the Great Lakes region. Percentage of disabled residents that are Medicaid enrolled and working. Again, in Ohio, 15%, Pennsylvania, Michigan, and Indiana, all in the bottom tier. And this is reported working if Medicaid enrolled and disabled by Puma region. In this case, it's this rural area, well, not always rural, but this band of counties north of Columbus that seem to be doing the best. Is that east central and north central Ohio areas that seem to be doing the best compared to the rest of the state, and southeastern Ohio seems to be doing the worst. So if you summarize the state comparisons, Wisconsin and Minnesota are in the top tier of all these measures. Illinois, Michigan, Pennsylvania are in top tier of some measures. Ohio and Indiana are in the bottom tier of all the measures. What we did, we wanted to ask what factors influence the likelihood that an adult with disabilities is working, and to what extent does enrollment in Medicaid have an impact on that. So we did a logistic regression model, and we included factors that were measured in the American Community Survey for this. We looked at gender, high school diploma, whether they had some college, their marital status, their race, age, poverty level, and whether they are enrolled in Medicaid. We looked at a whole bunch of other things too, but they weren't significant in the model. So this is the model results for Ohio. We did this for all the other states as well. So this shows that the indicators which have an impact on whether people with a disability are working. The highest is whether they're 40 to 59 versus 19 to 39. If they're 40 to 59, they're 2.5 times more likely to be working versus if they were 19 to 39. The older you are, the more likely you are to be working. The next is Medicaid versus non-Medicaid. 1.8 times more likely to be working if you're on Medicaid than if you're not. So Medicaid does have an impact. And then also ages 60 to 64 versus 19 to 39. You're 1.8 times more likely to be working. So all these measures predict the likelihood of a person with disabilities working, and Medicaid is significant. It was actually significant in all the models for all the states. And if you look at this model, which is repeated for other states, we use the same socioeconomic variables. They were significant in all states. There wasn't that much variation in the odds ratios. Medicaid enrollment significantly increased the odds of a disabled person working in all 7 states. So in Minnesota, theoretically, Minnesota has the strongest program with respect to an adult disabled person working. 2.85 times more likely to work, and Wisconsin was 2.37 times more likely to work. Conclusions for this whole thing. Medicaid enrolled 12,000 workers with disabilities. Most of them were already on Medicaid. The program cost the state less than it was budgeted, primarily because the patients were sicker. I'm sorry, they were healthier than what the state expected. Medicaid expenses were highest among consumers in long-term care settings and lowest among those who were dual eligible. And that's because Medicaid only pays the co-pays for acute care services. The Medicare co-pays for acute care services. There were differences between the Medicaid buy-in and DMA and Medicaid, other disabled Medicaid consumers. They were more likely to have a developmental disability. They were less likely to have a physical chronic health condition. They were less likely to have an inpatient hospitalization and less likely to have an emergency department visit. Their access to primary and preventive health services good, better than the disabled population as a whole. So the conclusions are the Medicaid program has been effective in improving the percentage of disabled adults who are working. The Affordable Care Act may have significant effects on participation in the Medicaid buy-in program. Medicaid buy-in consumers not in long-term care settings are more likely to choose the Medicaid expansion program because there are no employment requirements. Medicaid consumers above 138% of the poverty level are likely to stay in the Medicaid buy-in program because the premiums are lower and there are no cost-sharing requirements compared to the ACA. And then there could be a large influx of the disabled adults that are uninsured into the Medicaid buy-in program for the same reason. Here's our contact information. Open it up for questions.